Pernicious anemia and megaloblastic anemia are closely related conditions that involve deficiencies in vitamin B12 or folate, leading to impaired DNA synthesis and abnormal red blood cell formation. Here's an overview of both conditions. 1. Megaloblastic anemia. Definition: megaloblastic anemia is characterized by the presence of large, immature red blood cells, megaloblasts, in the bone marrow and peripheral blood. It results from impaired desynthesis that affects cell division, while RNA synthesis remains unaffected, leading to asynchronous maturation between the nucleus and cytoplasm of red blood cells. Causes: vitamin B12 deficiency. It is required for DNA synthesis, and its deficiency leads to megaloblastic anemia. B12 is also necessary for converting methylmalonic acid, MMA, to succinyl-CoA and for homocysteine metabolism. Folate deficiency. Folate, also essential for DNA synthesis, can cause megaloblastic anemia when deficient. Folate is necessary for the synthesis of purines and thymidylate, which are building blocks of DNA. Other causes: certain medications, e.g. methotrexate, trimethoprim, and conditions, e.g. myelodysplastic syndromes, can also result in megaloblastic changes. Clinical features: fatigue, pallor, and shortness of breath due to anemia. Glossitis, inflammation of the tongue, and chylosis, cracks at the corners of the mouth. Neurological symptoms, more common with vitamin B12 deficiency, including paresthesia, ataxia, and cognitive disturbances. Laboratory findings: blood smear, macrocytosis, increased MCV 100F ELR, hypersegmented neutrophils, and oval macrocytes. Bone marrow, hypercellular marrow with megaloblastic changes. Serum levels: decreased vitamin B12 and/or folate levels, elevated homocysteine in both deficiencies, and elevated methylmalonic acid, MMA, specifically in vitamin B12 deficiency. Treatment: vitamin B12 replacement for B12 deficiency, oral or intramuscular. Folate supplementation for folate deficiency, addressing the underlying causes such as dietary changes or discontinuing causative medications. 2. Pernicious anemia. Definition: pernicious anemia is a specific type of megaloblastic anemia caused by vitamin B12 deficiency due to the inability to absorb it. It results from the autoimmune destruction of gastric parietal cells, leading to a lack of intrinsic factor IF, which is essential for B12 absorption in the ileum. Pathophysiology: intrinsic factor deficiency. The parietal cells of the stomach produce IF, which binds to vitamin B12 and facilitates its absorption in the terminal ileum. Autoimmune destruction of these cells leads to decreased IF production, reducing vitamin B12 absorption. Autoantibodies: patients often have autoantibodies against parietal cells or intrinsic factor, further hindering B12 absorption. Associated conditions: it is often associated with other autoimmune conditions like thyroid disease, type 1 diabetes, and Addison's disease. Clinical features: symptoms of anemia, fatigue, pallor, dizziness, and neurological symptoms due to subacute combined degeneration of the spinal cord, paresthesia, numbness, ataxia. Gastrointestinal symptoms like a sore tongue, glossitis, loss of appetite, and weight loss. Potential hyperpigmentation and mild jaundice due to hemolysis of the abnormal red cells. Laboratory findings: similar blood smear findings to other forms of megaloblastic anemia. Decreased serum vitamin B12 levels, often with elevated methylmalonic acid, MMA, and homocysteine. Positive autoantibodies, anti-intrinsic factor antibodies, highly specific but not very sensitive, and antiparietal cell antibodies. Schilling test, historically used but not commonly performed now, a test for determining vitamin B12 absorption with and without intrinsic factor. Treatment: vitamin B12 replacement, usually through intramuscular injections, initially frequent, then maintenance doses, since oral absorption may remain impaired. Oral high-dose B12, sometimes effective for maintenance, as passive absorption can occur even without intrinsic factor. Lifelong therapy is usually necessary as the underlying autoimmune process persists. Comparison and key differences. Cause: megaloblastic anemia can result from deficiencies in either vitamin B12 or folate, while pernicious anemia specifically refers to B12 deficiency due to intrinsic factor deficiency. Neurological involvement: more pronounced in B12 deficiency, especially pernicious anemia due to its role in myelin synthesis. Autoimmunity: Pernicious anemia is autoimmune mediated, whereas megaloblastic anemia encompasses a broader range of causes, including dietary deficiencies and drug effects. Treatment. Both conditions require vitamin replacement, but pernicious anemia often necessitates lifelong intramuscular B12 due to absorption issues. Conclusion. Pernicious anemia and megaloblastic anemia are significant clinical entities with overlapping features but distinct etiologies. While megaloblastic anemia may result from multiple causes affecting DNA synthesis, pernicious anemia is specifically an autoimmune disorder leading to vitamin B12 deficiency. Recognizing the underlying cause is crucial for effective treatment and prevention of complications, especially the irreversible neurological damage that can accompany prolonged vitamin B12 deficiency.